So just to get started, for those that don't know me, my name is Camilo Galeano. I'm one of the attendings here at Kings County Hospital. It's nice to see a lot of new faces. And for those that don't know me, I graduated from this program a little bit over a year ago now. Um, and I actually gave this lecture about 2 years ago for the first time when we first started the Airway lecture series. This kind of came out of a QI project that I started where we started recording intubations that were done in our own department as a way of maybe like troubleshooting or kind of like doing like uh, a QI like for improvement. So after seeing like maybe like a dozen or a little bit more videos of intubations, I decided to make this lecture kind of on the tips and things that I saw. So this lecture is called Troubleshooting the Tube. I still like to thank the Airway team that helped me when I first started the lecture series because I think they were a big help for everything. So just let's go. So So step one, whenever you decide to intubate, really that's the first step that you take is to intubate someone. And then the first step that you kind of do is gathering your supplies. Now, when I first made this lecture series, ChatGPT's image creation wasn't that good. As you can see with this is what ChatGPT believes gathering your supplies would look like. But things that it clearly lacks is kind of kind of like the your you're going to be your laryngoscope and kind of your ET2. But what I think about for this step is kind of having a mnemonic in place or maybe a checklist. I grew up kind of on the SOAP-Me mnemonic, which stands for suction, oxygen, airway, positioning, meds, equipment, and tidal CO2. I don't think it matters which one you have, what mnemonic, what checklist, but as long as you have one, you'll be less likely to have any of your devices missing. So for me, equipment is kind of like the most important, and really this step is kind of choosing what weapon you're going to use, right? Are you going to be using an LMA to intubate this patient, right? Or to secure an airway? Or are you going to be using a fiber optic, right? This is all kind of based on the clinical picture that you have in front of you and the patient itself. Um, are you doing a direct laryngoscopy with using a Mac or a Miller blade like you see in the top left corner? And then you see that there's a lot of now these video assisted laryngoscopes or kind of like indirect laryngoscopies, where you're not actually directly visualizing the vocal cords that you're going to be intubating, but you're actually using a device to help you look around the oral pharynx to look at the vocal cords. So that's what I'm going to focus on because that's what the videos were. And most specifically, I'm going to be talking about hyperangulated video laryngoscopy using the glide scope, which we have. So step two is obtaining your view. So on the right-hand side, you see what's considered kind of like the ideal view for video laryngoscopy, where you have the tip of your laryngoscopy blade in the vallecula, you have your epiglottis, you have your arytenoids or your posterior notch, and in between those two things, you have your vocal cords. Now, your vocal cords take up the upper half of your video screen, with the lower half kind of being just the rest of your oral pharynx and kind of like your esophagus going down into the chest. So in order to start obtaining your view, the first step is usually opening the mouth. So on the left, you can have the scissoring technique. You put your thumb on the lower teeth and your middle finger on the top teeth, and you kind of just spread them apart. Or you could simply just push down on the teeth so far as you get enough space to insert your laryngoscope. Now, I usually recommend that as soon as you open the mouth and your laryngoscope is in place, you kind of remove your hand. A lot of times when you keep your hand there, you forget to use that hand to do something else. So if you free it to do something else, now what I usually recommend is putting your hand underneath the head. Now, if you're doing direct laryngoscopy, like in this picture, you can lift the head. It's a lot easier to lift the head with two hands and hold it than it is to kind of lift with just one. Now, it's not usually that heavy, but in the setting of you might be holding that head for a couple of minutes, you're going to tire out if you have to do the heavy lifting just with one arm. You can also make some small adjustments, whether it's leaning the head back or moving it to the side in order to get a better view. But I usually say as soon as you finish scissoring the mouth open and you have your laryngoscope blade in, remove that hand and kind of put it in the back of the head so you can do some more fine tuning. After that, the other thing that is most difficult, especially with our hyperangulated blade, is the insertion of a laryngoscope. I don't know if you guys can see my crude animation, but like you can see that the hyperangulated blade has a very acute angle to it. So when you're inserting the laryngoscope, what I often see is that you insert it straight into the mouth. But as you can see, it tends to get hung up in the middle of the tongue. It doesn't usually pass that. So the trick really is to do less of the insertion, a little bit more of a rotation, kind of towards you or counterclockwise in this case, which will kind of sit that laryngoscope in the perfect location. Again, the blade in the vallecula, activating the hyoepiglottic ligament, lifting the epiglottis, and exposing your view. So a lot of times when you'll have trouble inserting the laryngoscope, even though the mouth is wide open, it's oftentimes because you're kind of trying to force the laryngoscope straight in instead of kind of following that natural curvature, which is built to go around your oral pharynx. So slow and steady is the name of the game when it comes to this, what we call progressive laryngoscopy. So you should be looking out for landmarks as you insert your blade. The first being your uvula. It's kind of considered like a North Star that points the way. So once you see your uvula on your screen and you continue that slow progressive laryngoscopy, it should point to your epiglottis. Underneath your epiglottis is going to be your vocal cords. So and then eventually you'll get to your ideal view like we saw in kind of the beginning of this step, right? So quick warning. I actually put this for this. I didn't use this warning at the last lecture, but I got a lot of moans and groans for some of this context. So I decided to give you guys a viewer discretion this time. It's early in the morning and looking into people's esophagus, I get it. It's kind of nasty. But we're gonna take a look at some videos that we collected. So next video. So here what we can see, this is kind of a intubation. We're using the hyperangulated blade. Now, it is a midline procedure, but the hyperangulated or video laryngoscopy is very forgiving. Like you can see on the right side of the screen, we have this huge tongue. It's meaning we're a little bit to the left of the tongue. We're not necessarily completely midline. So a lot of times what happens is when we're inserting the laryngoscope, uh, when we hit the tongue and we don't follow that natural curvature, it tends to push us either to the right or the left side of the oral pharynx. In this case, again, we're having a little bit of trouble obtaining the view. We see our uvula there at the bottom, that little fleshy thing, and it looks like that might be the beginning of our epiglottis, but we're not getting a perfect view. So right now, it just kind of looks like a lot of pink material and just kind of the rest of the oral pharynx. Again, we try to go midline and we're kind of pushed again, kind of to the left side of the oral pharynx. Now, I think this is fine. A lot of times, the other thing that I do is just actually lift that laryngoscope. So even though we try to think about like the lifting of the handle in direct laryngoscopy, with video laryngoscopy, you open a little bit more of that posterior oral pharynx and maybe get the tongue and the mandible a little bit out of the way so you can see the larynx a little bit better. So in this case, we're having a little bit of trouble getting past the tongue and into our, now we kind of see it. You can see that hyoepiglottic ligament that the blade isn't necessarily in the vallecula, but it's approaching it. And now they probably lifted a little bit more, and now you can see that you have your vocal cords. Now, it's not a perfect view, right? We don't have the vocal cords in the upper half of the screen, but it's good enough to consider intubating, which now the ET tube comes in and a successful intubation is performed. Now, the other thing about this step is choosing your right weapon. So if you're going to be using the hyperangulated, I suggest using the S3. It's, I would say for 95 to 99% of patients, it's probably the ideal blade. S4 is the other option that we have, and then S2 and S1 kind of for more pediatric patients. But the S4 is pretty large. I think for most adult male and women, it's a little bit too big for them. And I can't confirm based on this case, but this is something that I think will happen if you decide to use like an S4 or maybe a laryngoscope that's a little too big. So here we kind of just jumped into it. We see our uvula at the bottom. We do progressive laryngoscopy, but we don't see the classic epiglottis in this case. We just kind of go into like, again, like kind of like a pink mesh and kind of lost in the sauce a little bit. So again, we can't really make out any definitive anatomy here. We're somewhere in the oral pharynx, but it's kind of hard to say where we are. Maybe something peaks up in the beginning. So we kind of go back to square one, back to our North Star, which is our uvula, and we go back in. So now actually what we're seeing here is the bottom of the trachea. So we're actually in the esophagus, and that fleshy, meaty part on the top is going to be our trachea itself. And so we've bypassed, and as you can see, as we pull back slowly, the posterior notch comes into view a little bit and our vocal cord. We do some suctioning and now we can actually see. So again, not an ideal view. The blade of the laryngoscope is actually underneath the epiglottis right now. Um, Kind of what you would do in like if you were using a Miller blade. But again, there's no way for me to confirm this, but it could have been that the laryngoscope blade was a little too big and we actually bypassed our whole mechanism and we went underneath the whole trachea itself. And that's why we were just seeing kind of pink because we're in the esophagus. Perfect. So obtaining the ideal is really as you can see, hyperangulated is very forgiving. You don't need a perfect view, you just need a view. Now, I think the hardest step in intubating, especially using video laryngoscopy, is step four, which is delivering the tube, right? So our goal is to intubate the trachea, right? We want to avoid the esophagus. Some say it's a 50-50 shot if you do it blind, but we want to be better than that, right? Now, the hardest part about this step is actually the way that we're intubating. So if this is a diagram of kind of what the process is when you're doing direct laryngoscopy, which is you have a patient that's just laying completely supine in bed, and the axis for laryngeal, pharyngeal, and oral axis are kind of perpendicular. You can get them a little bit better by putting them in a sniffing position, but the ideal thing is to actually, when you intubate, is to align them as much as possible so you can directly visualize your vocal cords. Now, we're not doing that with video laryngoscopy. It's kind of like an as-is intubation. We don't really move them. It might be because you're doing a cervical C-spine protection, or because it's the way that the intubation is done, which is kind of like a peek around your oral pharynx, right? You don't have to align your oral axis with your other axes. So because of that, you create kind of what we can call a double C. So the first C is being the oral axis, or kind of the curve um, of your hyperangulated blade, right? The second C is that naturally in the chest, the trachea kind of comes down. Um, so when you have a patient that's laying completely supine, you kind of get this inflection point, right? With the first C meeting the second C right around the epiglottis, just a little bit distal to the vocal cords. Now, as you can imagine, if you lift the head or you put a little bit, or you pull on the laryngoscope blade, you can lift a little bit of that first C and make that inflection angle a little bit smoother, right? It's just going to help you achieve a better first pass with your ET tube, mostly just for the tube delivery part. Now, the other thing that you can do is obtain that ideal view, right? The ideal view where you have your vocal cords at the top and you're seeing more of the posterior oral pharynx, also allows you to get a better inflection angle to deliver the tube. So now, because of the inflection point being past the vocal cords, usually what we say is that as soon as your ET tube hits the vocal cords, pop off that rigid stylet so that the ET tube is a little bit more malleable to bypass that inflection point. So this is also the grip that I recommend whenever you're intubating with a rigid stylet and video laryngoscopy. I kind of hold it like a pencil at the top. You don't need that much fine motor movement besides just popping off and maybe lifting and turning. So usually I say you have a lot more gross motor skills that you really need for this, and you're a little bit more comfortable just holding it at the top. Now, the other thing is that the ET tube has a bevel to it. And as you can imagine, when you hit that inflection point, your bevel's pointing up towards the anterior part of the trachea, and it often gets caught on these tracheal rings, right? So you'll often feel that you're trying to advance, and you feel like something is stopping your advancement. So the recommendation for if you run into this trouble is to turn your tube sideways. So if you're coming in straight up the top, just turn sideways and try to advance your tube that way. The thinking there is that your bevel will come off of those tracheal rings, as you can see in the bottom part of this slide, and you can advance your tube a lot easier down the trachea.
Quick question, do you turn it sideways before or after you enter the vocal cords?
So I do it before, right? Sorry, after. Once I hit the vocal cords and I feel like a little bit of a give, or I feel like I have some resistance, I'll turn it sideways and try to advance that way. So it's troubleshooting. Not every time that you go to intubate, you'll hit the tracheal rings, but sometimes you'll notice that you're trying to advance and you get kind of like what the ET tube will do is that instead of going in, it'll kind of bow down because it hits the top of the tracheal and the pressure kind of pushes it down. So what I'll do then is I'll just turn slightly and continue to try advancing until maybe we can get that bevel off of the tracheal ring. So looking at some difficulty, these are some videos looking at difficulty with ET tube delivery. So again, not an ideal view. We're a little bit to the left of the tongue here, but we see at the top, we see what our vocal cords, we see our posterior notch, and our ET tubes coming into place. And so as you can see, the tube is a little posterior, and actually we miss our intubation in this case. We deliver into the esophagus. We unfortunately miss our exit here. But we come back in, and the clinical team must have noticed that they intubated the esophagus. And this time we get a better view. Now we're to the right of the tongue. Again, we see our vocal cords at the top, upper 50%. And our ET tube is doing this thing where it's very posterior, right? It's not coming up to the anterior portion where our vocal cords are. It kind of wants to sit in the esophagus and the posterior aspect of our oral pharynx. But eventually we do get it up to the vocal cords and we have that tube advancement and we have a successful intubation. Now, the other tip is when you run into this issue where your ET tube is kind of sitting very posteriorly, naturally we kind of crank back on the ET tube. We do the kind of this posterior tilt, which does not translate to a significant amount of change in the anterior positioning of the distal ET tube. So the recommendation is actually to lift the tube entirely instead of doing this backward tilt. That way you go from this posterior aspect of the oral pharynx to kind of the anterior, and you're riding a little bit closer to your video laryngoscopy or video laryngoscope. Now, I usually recommend not going right in line with the video laryngoscope because you're going to occlude your view with the tube, and it's going to be hard to see where exactly you're going to be placing that tube. So looking at another video, it looks like this patient has some soot on their tongue. Again, we're having that trouble of going past the tongue. That might be because we're just inserting and not following that natural rotation of the laryngoscope and the tongue and the oral pharynx. We see our uvula, we see our epiglottis, again, very forgiving. And we see a good view, right? We have our vocal cords, looks like there's soot or maybe coffee ground emesis. We see our posterior ridge, and our tube comes into view. Now, we don't have this as much of an issue in this case where the tube wants to go a little bit posteriorly, but what we do have is that we're having trouble advancing the tube. As you can see, the balloon of the tube isn't really moving past the vocal cords. And as they try to push in, you see kind of that downward bowing of the ET tube. Now, it could be that the bevel is getting caught on the anterior tracheal rings. It could be that they didn't pop off the rigid stylet. You see the rigid stylet kind of come out there, and now the ET tube is able to go past. This is another case. So here again, we're kind of a little bit off midline. We see the tongue off to the side, that big white structure. We see our epiglottis up top, and we see our vocal cords. And I use this video to kind of show you that inflection point where you can see past the vocal cords and you see the trachea, but you don't see down the trachea. You see up into the anterior aspect of the trachea. And now when our ET tube comes in, it kind of hits the top of that trachea, and we have a little bit of trouble pushing it through. Now the rigid stylet comes out, but the balloon I assume goes through, but we don't see it actually go past. Here's another example. So again, we're kind of just like a pink wonderland. There's pink all around us. We can't really make out any of the landmarks or any anatomy. We see our uvula there, so if we follow progressive laryngoscopy, it peaked in there for a little bit, but again, this is kind of the situation where we're actually underneath the trachea. We didn't follow that natural curvature of the tongue. We just went right past it. the epiglottis pops in finally into view after we come back. And again, you kind of see that downward trajectory. We see the anterior tracheal rings for a second. It's not an ideal view. We don't see too much, but we go for the intubation anyway. And as you can see, when you don't have your ideal view, the ET tube tends to go a little bit posteriorly. Here, it really wants to go into the esophagus. Um, I don't know how they troubleshoot it, but they will. Um, but you can kind of see that there's a little bit of a struggle to get it more in the more anterior aspect of this view. So ET2 can, and this is the kind of what I mentioned about not having it completely in line with your laryngoscope. It kind of occludes your view completely. So that's why a more midline approach is better because you can bring that ET tube off to the side. Eventually, we do get it kind of in the anterior portion of our view. But again, we have a little bit of a hang up and we don't actually see the balloon go into the trachea. We see it kind of just in front of the vocal cords. Now they notice this as well, so they go back in, and here you'll see kind of the rigid stylet come out. The rigid stylet is coming out, and now your ET tube is able to progress, and we have a successful intubation. Here's another one. So view is great. Again, off-centered. We see our esophagus at the bottom. We have the vocal cords on the upper half of the screen. ET tube comes in. And it's a great intubation. So I just mentioned this part. It's just a salad technique. I hear a lot about, oh, you can't perform video laryngoscope on patients that have active emesis or have like blood in their oral airway. But this is a good video on kind of proving that you can use video laryngoscope and video assisted laryngoscopy to actually, this is the real viewer warning. Um, but we have an intubation where we have a lot of gastric content. It could be vomit, it could be blood. It's the same technique carries for both, but what you want to do is you want to ride a little bit high and tight to the tongue and again, do that progressive laryngoscopy and have your suction available. As you can see here, they were able to suction part of the all some of this gastric content. Some more comes in, but again, at no point are we occluding our view, or we can see everything that's going on, and we can continue. And here, we're actually able to see our vocal cords. We suction again because there's a lot of gastric fluid and gastric content coming into view. The one thing that I would do differently, which is part of our salad, is I would actually just park that suction catheter in the esophagus, right? As you can see, they suction and they remove the suction, but then some gastric content continues to accumulate. Now, at this point, it's not too bad, and they progress with the intubation. It's a great view. Your laryngoscope blade is in the vallecula. We see our vocal cords in the upper half of the screen. ET2 comes in, and we have a little bit of trouble getting past that posterior ridge. And again, we kind of get caught up on the anterior aspect of the trachea. We're kind of having trouble getting past the posterior ridge, and we're catching the arytenoids. But we troubleshoot. And finally, we're able to successfully intubate. But as you can see, that inflection point is pointing upwards towards the trachea again. But as the rigid stylet comes out, we are successful in intubating. Now, parking the suction might prevent some of this gastric content going down into your airway. As you can see, a lot more starts coming out. So, so I do want to finally give an Oscar for the best video laryngoscope, which is this video. Easy view, perfect view. The ET tube does come in. They have a little trouble. It wants to ride a little bit more posteriorly, but they're able to troubleshoot it and intubate the patient in under 15 seconds from start to finish. So I'll take any questions.